Hello everyone, this is the Road Nurse back with another video. Still, obviously, I'm new at this, so I apologize for any quality issues or any things that may be wrong with the videos. You certainly learn as you go with things in this nature, so I'll try to get better as things go on, but please bear with me. Anyways, I want to stick with hemodynamics, and I really want to focus on hemodynamic parameters. And I will start with preload. So, what exactly is preload? Preload is the pressure in the ventricles after systole. That's a big way of saying that the heart pumped and it's resting, and that's how much blood is left in the ventricles. So, two things can happen where things can be normal, things can, of course, be abnormal. So, to start, you can have a high preload. Now, what causes a high preload? Quite a few different things. So, people with congestive heart failure, they have a problem with, essentially, it's a pump problem where the heart just isn't beating effectively to get that blood out. CHF is a whole different topic on its own that I will probably make a video about later. Another cause is cardiogenic shock. Now, somebody that has a history of CHF during an exacerbation, they can go into cardiogenic shock. But there are also a multitude of things that can cause cardiogenic shock, which is also a whole different video, and I will eventually get into shock and everything. So, continuing on, hypervolemia. An excess of fluid volume can certainly be an issue with high preload. This manifests a lot with edema. You see a lot of swelling in ankles, legs, sometimes even hands of people with congestive heart failure. Another manifestation, which is one to really look out for, is lung sounds, crackles. You can hear the fluid in somebody's lungs, and obviously if that gets bad enough, that's a huge issue that needs to be dealt with right away. So we have edema, crackles from the fluid in the lungs, and you can also see jugular venous distension. Now, you have to be careful with this because if you just look at somebody for the first time, that could just be normal for them. Maybe their jugular vein is just naturally a bit more distended than you are used to seeing. However, if you see somebody over time and you know about what their normal is, and you see that their jugular vein is starting to distend, and especially if it's really noticeable, that could be a problem. And two more things that I'll get into later in also a different video. Central venous pressure. If you have 6 or more millimeters of mercury, that's a good sign that your preload is too high, as well as pulmonary catheter wedge pressure. If that is 12 or more millimeters of mercury, that's also another sign. But I will get into those, like I said, later. Lastly, Brady dysrhythmias. What does that mean? The heart is beating too slow. So if the heart's not beating fast enough, blood is collecting in the chambers, and that's building up that preload. And there can also be a multitude of reasons for these dysrhythmias. And dysrhythmias will be also a different video. But just know that if your heart's not beating fast enough, you have more blood collecting in the heart. So what are the treatments for high preload? Big treatment is getting rid of that fluid. How do you get rid of that fluid? Diuretics. Different diuretics work in different ways, but the concept as a whole is get that fluid out of there. Diuretics will pull that fluid out and allow the kidney to excrete it. Another good preventative measure so it doesn't get worse, or maybe so that it doesn't get so bad to begin with, is fluid restrictions. A lot of times you'll see patients with congestive heart failure and with chronic kidney disease on fluid restriction because of this reason. They can't get rid of the fluid as effectively. It builds up and it causes problems. And lastly, ACE inhibitors. What do ACE inhibitors do? ACE inhibitors allow blood vessels to dilate more. So angiotensin converting enzyme is responsible for a lot of vasoconstriction. So if you block that enzyme, you have less constriction, lower blood pressure, bigger pipes, more room for the fluid to go so that it can get out of the heart and to the rest of the body. So going back up, like I said, if things can be high, they can be low. So what causes low preload? If hypervolemia causes high preload, hypovolemia causes low preload. If you don't have enough fluid, there's just not enough blood circulating. That preload is way too low. Another problem can be increased intrathoracic pressure. This is especially a problem for people on mechanical ventilators because they're artificially getting more pressure pumped into their lungs, and our intrathoracic pressure does increase when we breathe naturally, but being on a ventilator, artificially getting your lungs inflated with that positive pressure can cause problems as well. Also, cardiac tamponade. This is that fluid collecting in the pericardial sac, so it's increasing the pressure on the heart. The heart doesn't have enough room to move around, so it kind of gets stuck with all that fluid around it, and it can't beat effectively. And one of the hallmark signs of cardiac tamponade is narrowing pulse pressures. And once again, that's because the heart's not beating as much as it could, so that systolic and diastolic pressure start to narrow, come together. And another sign of this, use your stethoscope, listen to the heart. Muffled heart tones is a big one. Sounds like that heart's underwater, so you can even hear it. Tachydysrhythmias. So again, kind of opposite the bradydysrhythmias. If the heart's beating too slow, you have a buildup of fluid. If your heart's beating too fast, you don't have enough time for that fluid to build up. It takes a certain amount of time to get enough fluid into the heart to then eject it into the rest of the body so that it can do its job. And lastly, atrial fibrillation. If you lose that kick from the atria, if you lose that atrial kick, you will lose some of the ability for the heart to get blood throughout the rest of the body. And that's another thing that is for another video. So what are the treatments for this, for low preload? Fluid. Replace the fluid. If you don't have enough fluid, get more fluid in there. Normal saline, lactated ringers, whatever it may be, they just need more fluids. Now, there are some situations where what they need instead of fluids is a blood transfusion. Especially somebody hemorrhaging internally or with trauma, they're just bleeding out. If you replace that blood with fluids, eventually that's going to cause some problems. You're going to just turn that blood into Kool-Aid. Fluid can't transport oxygen. Fluid can't clot. So you're causing coagulopathy as well as lowering the hemoglobin so that they're still not getting oxygen. And just in certain situations, fluid isn't enough. They might need that blood transfusion. Also, if they're on vasodilators and their preload is really low, you can consider decreasing the vasodilators, or even considering if they still need them, such as Levophed, norepinephrine. Similar to how I mentioned ACE inhibitors will allow for more dilation of the blood vessels. Vasodilators, it's in the name, dilate the blood vessels. So if you don't have enough fluid, that's a huge problem, and you need to get those blood vessels smaller so that your blood pressure comes up, preload comes up, and there you go. So that is all I have to say about preload. Coming up next will be afterload in a separate video. Thanks for sticking with me through my new content creator struggles. So thank you very much.